post-exposure prophylaxis. So in TLD regimen, okay, so TLD regimen is given in more than 10 years of child in antiretroviral therapy, but it is also given post-exposure prophylaxis. If there is a chance of infection in child, we give prophylaxis to prevent further increase in infection or increase eruption of infection. So tenofovir, lamivudine, and dolutegravir, we all know that we have already read. And then OD at same time every day, preferable at night because more compliance, and gap of 2 to 3 hours after food. So if you take a food at 7 o'clock, we have to take a medicine at 10 o'clock. The duration for 28 days and initiation ideally less than 2 hours and maximum 72 hours. So if you have a sexual intercourse with a like HIV patient, or if you have a uh, injury, Dale stick injury, so you have to take a prophylaxis which is TLD regimen and TL or LPVR regimen is tenofovir, lamivudine, TL, LPVR. This is rat. This is all. This is prophylaxis. Then you have prevention of opportunistic infection. So most common opportunistic infection is TB. So if you have less than 500 count of CD4, we get a chance of TB, herpes zoster, oropharyngeal candidiasis, Kaposi sarcoma, NHL. I don't know about NHL. No, not non-Hodgkin's lymphoma NHL is. And less than 200 of CD4 count, we get pneumocystis, zirvoki, esophageal candidiasis, wasting, fungal pneumonia. Less than 100, we get brain damage, cerebral toxoplasma, cryptococcus, cryptosporidiosis, cytomegalovirus. In if less than 50, we have MAC, Mycobacterium avium complex, cytomegalovirus. It is a typical mycobacterium and cytomegalovirus. So in primary prophylaxis, we prevent the occurrence of opportunistic infection. Secondary, we prevent the reoccurrence of opportunistic infection. So mostly against tuberculosis, which is pulmonary, and pneumocystis zirvoki, most common is pneumonia. And in secondary prophylaxis, will give like recurrence of will prevent all opportunistic infections. So prevention of opportunistic infection, we have a less than 50, less than 100, less than 200, less than 500 count based on. So less than 50 is mycobacterium avium complex or cytomegalovirus. Less than 100 is cerebral toxoplasmosis or cryptosporidiosis, which is a fungal infection, cytomegalovirus. And less than 200 is pneumonia, pneumocystis jirovecii, or esophageal candidiasis or wasting syndrome, fungal pneumonia. And less than 500, there's a chance of TB and herpes zoster or oropharyngeal candidiasis, Kaposi sarcoma, or non-Hodgkin's lymphoma. We have these. And then we have prophylaxis for TB. We have post exposure and normal prophylaxis. So prophylaxis of TB in like HIV patients. So TPT regimen, TB prophylaxis therapy. So 6 months of isoniazid and 3 months of isoniazid, or 6 months of isoniazid, or 3 months of isoniazid and rifampicin plus pyridoxine. Pyridoxine should be given when isoniazid is given, because isoniazid causes some like toxicity. We'll see that once. So we have to decrease neuropathy. To prevent B6 deficiency. So, given to all people living with HIV after ruling out active TB infection, because if people get TB, there's a different regimen, and indicated for age more than 1 year, and for less than 1 year, dose calculated by weight, and for prophylaxis of pneumonia till we get a more than 350 cells per millimeter cube on two occasions, 6 months apart. Plus rising trend of CD4 count or asymptomatic for HIV stage less than 3. So drug of choice is trimethoprim, sulfamethoxazole, double strength, duration for 6 months. CD4 count more than 350 for millimeter cube, trimethoprim, sulfamethoxazole, sulfamethoxazole, pre-exposure prophylaxis. So in high-risk individuals, risk of unprotected sex, prior history of multiple use of PEPs, zero disordered relationship, not able to use barrier method, mode of action. So inhibits entry of ISR wireless replication, 90% effective in sexual mode of transmission, anal intercourse transmission for 7 days, vaginal intercourse transmission more than 20 days, consistency use 90% efficiency, TDF regimen, TDF plus lamivudine at same time every day, TDF in the sense tenofovir, dolutegravir, tenofovir disoproxil fumarate plus lamivudine. So contraindications are signs and symptoms of confirmed HIV. In this, we have to give post-exposure prophylaxis, which is tenofovir lamivudine TLD regimen. So weight less than 30 kg, we should not give TDF regimen, and renal function and 60 ml per minute of estimated creatine clearance. Checked gender factor 40 years minus 140 by age by serum creatine into weight by 72. Unwilling or non-complement patient, we have to not give pre-exposure prophylaxis, and then we'll see Strategies, organization, and indicators. So strategies, it is integrated counseling and testing centers. HIV, it we have to eliminate the stigma related HIV and counsel the patient and discrimination. So there is an integrated counseling and testing center. So HIV screening level standalone ICTC integrated counseling and testing specialized laboratories in major cities, high burden area, uh, who have red light areas like that. Facility integrated ICTA centers, most common cost effective addiction of ICTC facility in existing laboratory. uh, Standalone facility integrated and mobile in semi-urban or low load areas. So we have three levels: standalone at endemic areas of HIV, so high burden area, and then we have facility integrated ICT, additional ICTC facility in existing laboratory, and we have mobile standalone facility and standalone facility and mobile standalone facility in mobile. So TB and HIV is most common opportunistic infection. So start antiretroviral therapy. 6 months of will give isoniazid, or 3 months of rifampicin or isoniazid. If patient doesn't infect with TB, which is prophylaxis, but if patient is already infected with TB, we have to give start antiretroviral therapy. Rifampicin is replaced with rifabutin. Infectivity decreases by 90 to 95% in first 2 weeks of therapy. Start antiretroviral therapy after 2 weeks of ATT initiation. Start anti-tubercular therapy. So after initiation of TB treatment, we have to start antiretroviral therapy. So reasons for not initiating treatment with ART or immune reconstitution, inflammatory syndrome, or hyperimmune to antiretroviral therapy, or flares up TB infection. Immune reconstitution, inflammatory syndrome, hyperimmune to. So bidirectional screening. So we'll just revise the treatment of TB now. Mm, so we have to test for drug sensitive. We have 2 months of HRZD and 4 months of HZD, and if only mono or poly DR drug resistant TB, we have 6 months 0, or if ampicillin resistant or multi-drug resistant, we have 4 to 6 months of CHOPZ and COSI, and extensively drug resistant, we L2 C2 B2, bedaquiline. With C we have clofazimine, isoniazid, levofloxacin, bedaquiline, pyrazimide, ethambutol, ethionamide. And L2C2B linezolid, levofloxacin, cycloserine, clofazimine, and we have bedaquiline. So in pregnancy, beta-lacimine is used, which is bedaquiline, uh, linezolid, pre- pretomanate is Pritomanid, Bepalogemin for 24 to 26 weeks. For 24 to 26 weeks, 8 to 9 tablets per day. So guidelines is bidirectional screening. All TB patients screened for HIV. All HIV cases screened for TB. CBNet first investigation of choice for diagnosis of TB in HIV patient due to increased chance of sputum negative reports or extrapulmonary TB. Prompt initiation of antitubercular therapy. ART initiated post 2 weeks of ADD initiation. TB preventive therapy to all HIV cases. We have bidirectional screening, which you have to use CBNAT, and we have to start ADT before ART because of hyperimmunity or immune response, immune reconstitution, inflammatory syndrome, or flaring up of TB infection. And then we have Suraksha Clinic, which is early diagnosis of TIs and STIs, syndromic management of STDs. So we have syndromic kits also, which are gray, green, white, blue, red, gray, green, white, blue, red. So red is for herpetic genital ulcers. Ulcers are red, so red. So tablet is isoclovir. Please remember the tablet. We can't remember dose now. Isoclovir. And then for blue, non-herpetic genital ulcers with penicillin sensitivity, we give doxycycline plus azithromycin. In non-herpetic genital ulcers, penicillin, azithromycin, disposable syringe. If we have penicillin sensitivity, we give doxycycline. Then we have vaginal discharge, green bacterial vaginosis. We give fluconazole, secnidazole. Fluconazole, secnidazole, gray, which is discharge, erosions, urethral discharge, painful scrotal swelling, anorectal discharge, which any discharge or erosions and swelling. We give azithromycin stat or cefixime tap. We have all tablets only except for white. We give injection. It is non-herpetic genital ulcer. Will give penicillin, and azithromycin tablet. So we have kits, and we also have a yellow and black kit. Yellow for pelvic inflammatory disease or lower abdominal pain. We have cefixime, metronidazole, doxycycline, and inguinal bulbo black, doxycycline, azithromycin. For blue kit also we give same doxycycline and azithromycin. HIV zero surveillance, sentinel surveillance, finding the bridge, missing population to bridge population, transmit HIV from core to at risk population. So HIV zero surveillance is very important, guys. So to find missing cases, bridge population, transmit HIV from core group to at risk patient. At risk patients are partners. Others at risk, bridge high risk female sex workers, men having sex with men, injectable drug users, or transgender. General or pregnant women, proxy indicator of general population. And we have bridge population, which means single male migrants, long distance truck drivers. So duration 3 to 6 months. For every 2 to 3 years, 3 years. In the age group of 15 to 49 years, we have to do zero surveillance. Every 3 years we have to do a 6 months of 2 to 3 years we have to do 3 to 6 months of survey. In the age group 15 to 49, testing strategy is unlinked anonymous testing. Unlinked anonymous testing is all blood donations are screened, and subject can be chose to be informed of HIV status. So notice TB is 100% notifiable disease. We have some six disease: CY, PIP, CY, PIP C. We have cholera, yellow fever, plague, influenza, polio, cholera, yellow fever, plague, influenza, polio, which is a notifiable disease. So testing protocol, anonymous test. First HIV testing, which is if it is reactive. Second we have to do if it is non-reactive, negative. If it is reactive, it is positive. If it is non-reactive, it is negative. And screening, it is three-step surveillance, which include ELISA, two other tests like screening test, and population is not included for serosurveillance or STD clinics, TB centers, fishermen, because up to avoid duplication, we already do that. And other strategies: condom promotion, safe blood practices, link work scheme, red ribbon awareness, HIV awareness training, distribution of deluxe node condoms and female condoms for rights of population. And voluntary workers for distribution of antiretroviral therapy and management of HIV cases and spread awareness. We have organization like diagnostic centers at standalone at state and district facility, ICTs, sub-district and village, and mobile at low urban areas or rural areas in treatment in premium institutions, district hospitals, ART plus sub-district levels, community. So in community level we have voluntary workers, sub-district level we have and CHC, and CHC we have link ART centers and link worker. Sub district and CH level we have link ART centers and link worker. District level and at district hospitals and medical colleges we have better diagnosis, second line ART, in premium institution medical college research in HIV. So community level, sub district or CHC level. So HIV is completed, guys.